So can you talk about the different treatment options that are available to men who have 3 plus 4 equals 7 and kind of what sort of cases they would need to have to match up with those treatment options?
So 3 plus 4 equals 7, if there's very, very small amounts of grade 4, then those men can consider active surveillance. It has to be low volume, it has to be very small amounts of grade 4. But historically, we've thought it was only 3 plus 3 that could do active surveillance. But certain patients with 3 plus 4 might be candidates for active surveillance. That would be to simply just watch it and forego treatment altogether for the time being. Other types of 3 plus 4, if there's larger amounts or if it's bilateral and it needs treatment, will respond to just about any type of treatment. They're so easy to cure. The chances of 3 plus 4 spreading within 10 years is probably in the range of 10-15%. So you name the treatment and it will work. So usually people try and move towards something, simple, effective, and non-toxic. We often will put radioactive seed implants toward the top of the list, or if it's a unilateral disease, some sort of focal therapy.
So switching gears a little bit and going into, let's say, grade 4 being more prominent in the prostate when they're getting the reports back, what treatment variations do you suggest versus 3 plus 4 in regards to the fact that is it harder to treat? I mean, I would consider with Gleason 4 being there, they can't just choose the same treatment that they would if they had more 3. What are the differences?
Yes, the general policy for Gleason 4 plus 3 is to use a combination of seed implant plus some beam radiation plus a short-term treatment protocol with like 4 months of hormone treatment to block testosterone. And that has become pretty standardized. The surgeons still like to operate. I don't think they're getting as good outcomes, but the urologists are still believers in radical prostatectomy for 4 plus 3. There's a lot of variables, of course. Some people, if they just have one little spot of 4 plus 3, might be candidates for focal therapy. If it's low volume 4 plus 3, the seed implant doctors are arguing that they're getting such great results that you can just do a seed implant alone. You don't need any hormone therapy or any beam radiation. And that policy or that theory is being supported more strongly by these new PSMA PET scans that are being performed when they don't show any spread. So one of the reasons people would get IMRT is to cover the surrounding lymph nodes as sort of an insurance against the possibility of small specks being present that were invisible on most scans. But the PSMA PET scans are so accurate now that if the scans are clear, many doctors are thinking, well, maybe we don't even need to do the IMRT to the lymph nodes. Maybe we don't even need to do the hormone therapy. Things are changing because technology is changing. But if you look at what the standard has been for the last 10 years, it would be a seed implant plus IMRT plus 4 months of Lupron type hormone therapy.
So when you talk about seed implants, there's LDR, HDR, so low dose, high dose, there's temporary, there's permanent. What do you suggest in those circumstances? Is it all the same? They kind of work the same? Or is it,
Well, the permanent seed implants are much more convenient. It's an outpatient procedure. And probably for every person that has temporary seeds, there's, 25 or 50 people that have permanent seeds. The temporary seed implant doctors are very good at handling large tumors and ones that are in the seminal vesicle or outside the edge of the gland. And so I tend to think of the temporary seeds for the men that have the more serious, large tumors, and the permanent seed implants for most everyone else.
So talking about seminal vesicles, now when it comes to treating those, that kind of, to a lot of people, that's, really scary, like, oh, it's traveling, and I totally understand that. So can you explain the seriousness of the situation when it goes to the seminal vesicles? What does that mean? And then also, is there any sort of loss of function that can occur if they do treat the seminal vesicles, and how maybe they can handle that?
The reason that gets everyone's attention is it's going to be a somewhat larger tumor to get all the way up to the seminal vesicles, number one. Number two, it's been shown that microscopic spread to other areas of the body occurs more frequently in people that have seminal vesicle invasion. So it's a suggestion that there might be some specks somewhere outside the gland, which argues for hormone treatment, radiation to the lymph nodes, all those things we discussed. So It's not that much more difficult to treat the seminal vesicles. They do run along the side of the rectal wall, so the doctors have to be skillful not to cause any damage to the rectal wall. But they're treatable, and it's primarily a prognostic issue, is raising this question, is there any microscopic spread? It's already in the seminal vesicles. Maybe it's gone somewhere else as well.
So do you suggest in that situation where maybe they do see that seminal vesicle invasion, they're looking for that microscopic spread, what do they do to kind of figure out whether that's happened or not? What's the next step?
Well, the PSMA PET scans are a logical step at this point, but then because spread could be microscopic and any scan could miss it, then the idea of using longer-term hormone therapy, maybe beyond 4 months, and of course the prophylactic radiation to the surrounding lymph nodes.
Thanks for watching. If you would like more information about the topics we discussed today, you can go ahead and visit our website at PCRI.org. Don't forget to subscribe to our YouTube channel. We come out with new videos every single week.